Well, it's a little bit wild how in history, the number of men who claim, particularly anatomists, who claim to discover the clitoris, like as if women didn't know where it was, discover it, name it, find it, lose it. It's lost in Grey's Anatomy. But, oh no, but here it is. And it's like this tiny little thing. And yeah, that was comical.
My guest today is Dr. Elizabeth Comen. She's a medical oncologist and associate professor of medicine at NYU and the author of All in Her Head. In her work, Dr. Comen looks at how women's bodies and symptoms have been minimized, misunderstood, or dismissed throughout history, and how those same ideas show up in healthcare today. And this conversation is really about why women's health has lagged so far behind, why menopause and midlife symptoms are still brushed aside, and why Black women's pain is so often discounted. We're going to talk about sex, quality of life, the need for a little humility in medicine, because listening to women may be one of the most important things we as physicians can do to improve care. Welcome to The Second Opinion, Dr. Comen.
Thank you so much for having me. I'm such a huge fan of yours, and it's an honor to chat with you today.
I guess where I want to start is, where did this idea, just the fact that, hey, women are just small men, how did that become so entrenched in medicine?
Oh, I think it's been there forever, since the beginnings of Western medicine, from Greek and Roman thought, the idea that we were whether inverted, imperfect, flawed versions of men has been carried out through medical history, and in some ways mirrors the cultural ideas of us throughout, thousands of years.
I want to start because I wanted you to tell a little bit of the story, if you will, about Sir William Osler. Who is, we have been taught, he's the father of modern medicine.
I know, right?
And he's transformed everything. That's all I know. I have these wonderful quotes from him because I'm like, oh my God, he's the father of modern medicine. Tell us a little bit about him.
So what's really interesting about these people in history in general is that, it's hard to go back in time and imagine what life was like for them. And I do give a lot of grace. I don't know who I probably would have been in an asylum for, romanticizing sex or something, and killed off in some other place or burned at the stake. So, it's hard to really know what it would have liked to have been him, although I'm thinking we would not have been friends. So he, as you know, was considered the father of American medicine in many ways. He was Canadian, but out of Hopkins, he really developed our residency system, the way that we train, and all those grueling hours and living in the hospital, which is not such a bad thing when you really want to understand medicine well. But he also wrote this treatise on heart disease, and is really one of the reasons why so much of medicine refers to cardiac issues in women as atypical. And what was so shocking is I read the primary literature, what his treatise that he wrote about heart disease, and case after case after case in men was really structural, or something terrible happened, or they were having a heart attack, or it was the gray-haired man that was running his engines too much and clutching the elephant on his chest and having a heart attack. And then every case about a woman he refers to as having some form of neurotic angina. So basically chest pain that's all in her head, which is maddening because you and I both know that the number one cause of death in women is heart disease. And so it was really mind-boggling to me. He even had a line in this famous treatise on heart disease that said, "These women do not die," which is absolutely not true. And so we wonder why women are still dismissed in emergency rooms as having anxiety, or more likely to miss a heart attack in women. Because so much of what we learned, I think you and I also in medical school, came from this man kind of laying the foundation for what we're supposed to understand about medicine. Another interesting fact about Sir William Osler is that he did not think women should go to medical school. I happened upon an article in the Washington Post where there was a medical student named Dorothy who said she ran into Sir William Osler on the medical school campus. And when he found out that she was there for medical school, he told her to go home.
Well, one of the things in your book that I just found fascinating is that this notion of what women were supposed to be, and really how women were perceived in the 19th century. And there was this idea of women, the ultimate and femininity. So describe for me, who was the ideal woman in the 1800s?
I think it depends on where you lived, but the ideal woman was certainly more submissive to the man, was quieter, ran the home, was not educated in the same way. And if you look through, at least in terms of women's education and medical school and medicine, the idea that women could even sit at desks and study, the fear was that they might have scoliosis from that. They might have reproductive issues and not be able to have regular periods. I mean, just the idea that women could be in school and that their periods would not aberrantly affect their capacity to reproduce one day because they had a finite amount of energy and only so much could be distributed from the brain to the uterus. I mean, there were so many things that were just simply outrageous, including what we could eat and what we couldn't eat, that red meat might cause us to be too voracious in our sexual drives. I mean, depending on where you go in medical history, it's really quite remarkable. You talk about behaving, but so much of the medical literature around women's health and our bodies about how we are controlled, how we behave, and how we submit.
And the ideal was sort of based on frailty, like that was a good thing. So, the thinner, the whiter, the more incapable you were of doing things were things that were really revered. And it's just so unfortunate. But when I think the story that really just took me over the edge when you were talking about how we romanticized women with tuberculosis.
Yes. Yeah. So this whole idea of the dying beauty, the Ophelia from Shakespeare, sort of pale and thin and frail and coughing up blood, for God's sakes. I mean, it's really awful. But then, think about the 1990s and heroin chic, or what we're looking at today in Hollywood with some of these women on GLP-1s going from a size 2 to a size 0. We have always romanticized in some way or another in history, and it might ebb and flow, the weaker, frailer woman. And we wonder why so many women don't know how to strength train, are afraid that when they go take a Pilates class, that they're going to bulk up. Or if they lift weight, I mean, I lift weights 6 days a week almost. And, you can't see my full body, but I'm not exactly Hulk Hogan or Arnold Schwarzenegger. And yet this was never part of my medical training. It was never part of my, athletic training about how we can keep our bodies strong.
When we have this perspective about what is valued in this society, when we sort of overlay race onto that conversation, it's important for everybody to understand that this societal ideal of femininity and what was beautiful was something that was never available to Black women. Black women in this country have never been allowed to be fragile or protected. And that has a bearing on how we've been treated within the medical community. And this would be a good time to bring in one of our other men of medicine, the father of gynecology, J. Marian Sims. And let me tell you, Elizabeth, I'm from Alabama. Okay, I'm from Mobile, Alabama. I had never heard of J. Marian Sims until, I don't know, maybe 2008, when there was the whole controversy about taking his statue down in Central Park. So tell us a little bit about my gynecological colleague, Dr. J. Marian Sims.
Well, I read his autobiography. It's quite fascinating. But as you know, one of the most complicated obstetric complications can be fistulas. So women during childbirth, where the baby's stuck in the vaginal canal, can have these tears in their tissue that connect the bladder to the vagina, or the stool can come through the vaginal canal, and it can be absolutely awful. And women can die during childbirth. And if not, they're sort of left in this cesspool for the rest of their lives, like urinating or stooling themselves. And it's really awful. And it was one of the tragic complications of not tending to women over time. In my book, I go over an Egyptian mummy who was found a famous princess who was found to have this fistula and died thereafter. And these women were historically ignored in the medical community and sort of ostracized. In comes Marian Sims, who developed a modern technique for repairing these fistulas. But what I never knew, and I suspect you did not know until recent history, is that he did this on the backs of, it's just so horrific reading about it, Black female slaves. And at the time, even though anesthesia was evolving, these women had no anesthesia. Certainly, they were not consenting in the same way that we think about consent. You can only imagine how torturous these procedures must have been over and over and over again. And so in many ways, he changed the future of gynecology by learning how to correct these repairs and helping women in the future. But again, he did it in the most barbaric, horrific way. And it's very, very, very challenging to read his autobiography and to read the history and to see just his place, his very complex place in history.
You know, I was able to go to Montgomery, Alabama, just a few years ago. It was the first time I had actually seen his statue. The statue of Marian Sims is gone from Central Park, but it is still on the grounds of the Alabama State Capitol. And there is a wonderful woman by the name of Michelle Browder. She's an artist and she's a historian, local historian. And what she has done is that she has erected monuments to those three women, the only three women that are named, Anarcha, Betsy, and Lucy.
Yes.
And she has these wonderful statues, and they're actually sculptures, statues, and they're called the Mothers of Gynecology. She says, and this is the antidote to Marian Sims. If he's the father of gynecology, then understand that he did so on the backs of these, literally on the backs of these Black women who he experimented on. And I think to add to the indignity, it's not just that he operated on these women without anesthesia. That's bad enough. But he did it in public, in public fora, in front of other people without anesthesia, and then enlisted the help of these women to take care and to be the surgical assist for his procedures when he did it on other women. And I think that that is the root of this strong Black woman myth that we have, is that the notion that even today that Black women don't feel pain the same way. We don't need to be medicated, on and on and on. But it has its roots. And that's why it's important that we tell that Marian Sims story.
And I think that just doing the research for the book, just really understanding how the compounded effects of misogyny and racism really are just extraordinary in this country. And as you said, really play out in terms of how we address disease, how we address pain, what resources are available to patients. Yeah. And it was very, very, very challenging to learn that history, because it's not something that I learned at any point in my education.
You're right. And I think that your book, just that history should be required reading for not just med students, but because there are a lot of practicing physicians out there, and I can put myself in that group, that just don't know this history. I mean, for me to have gone through an entire residency and practiced gynecology for as many years as I did, and we have instruments named for this man, we have positions named for him, and yet I had no idea. It's like, oh yeah, he's the father of gynecology. Even the parts of women's bodies are named after men. And that is just amazing. It's like, oh, you just discovered that? Who knew there was a Dr. Fallopia for fallopian tubes? Yeah, it's
a little bit wild how in history, the number of men who claim, particularly anatomists, who claim to discover the clitoris, like as if women didn't know where it was, discover it, name it, find it, lose it. It's lost in Grey's Anatomy. Oh no, but here it is. And it's like this tiny little thing. And yeah, that was comical.
Yeah. And I think you even wrote about the fact that someone speculated that this would eventually, this vestigial figure of organ will probably go away.
With evolution. We didn't need because it. we don't need it somehow, of course.
This is a wonderful segue, because I do want to get into the history of how we viewed women's sexual health and our sexual pleasure. And clearly, I think it's safe to say it's never been historically or medically prioritized. Will that be fair?
It still isn't.
Yeah. All right. So we're going to put in some of our little cast of characters here. Dr. Horatio Storer, who was also, he was quite something. And he was a gynecologist, right?
Yes, he founded the Boston Gynecologic Society. And I mean, I just fell down the rabbit hole researching this man. And it started because I found this is really one of the inspirations for writing the book. I found this case report in one of the famous Boston medical journals where he's evaluating this woman, Mrs. B. She's brought by her husband to see him because essentially she's dreaming about sex too much. Her sex drive is too voracious. But if you read the actual case report, it sounds like he has erectile dysfunction. He's saying that, meaning the husband, that there's some sort of obstruction when they go to have sex. But really, it sounds like he has erectile dysfunction. But who's got the problem? It's the woman. It's this younger wife that wants to have more sex than her husband can provide. And what's the solution? Well, let's put needles in her pillow. Let's put chemicals on her clitoris. Let's stop her from reading books and eating meat. And if that doesn't work, we're going to send her to an asylum. And the crazy thing is, I said, well, what is this? Who is this Horatio Storer guy? He sent his wife to an asylum at age 39 for basically PMS, where she died. She died in an asylum in Worcester, Massachusetts. And then this is the part that I couldn't get over. I found some journals that his best friend from Harvard Medical School had published, where he talks about how Horatio Storer would use a poker, like a fire poker that you would use and stick it up female cadavers in the basement of Harvard Medical School as if this is normal behavior. So when we think about who founded these societies and why do we not value certain aspects of women's health, like sexual health today? Well, the people that founded these societies didn't. And so much of medical history was really about controlling the narrative about women's sexuality and certainly their desire.
I think when we're talking about women and women's health and sexual health, I think that there are a few, we have yet another overlay to this conversation. There's misogyny, there's racism, and then there's a lot of perversion to go along with it. I mean, these men were overly obsessed with controlling women's sexuality, and the types of things the lengths that they would go to control it were actually pretty twisted, I would say.
I mean, very twisted. When I was unpacking the history of women's health, I did not expect at every turn there to be something sexual. Now, truth be told, I love talking about sex. It's fun. But this research was disturbing.
Yes.
Like, you got scoliosis, it's because you the masturbation thing was wild. You masturbate too much. You have asthma, you masturbate. I feel like at every turn in history, every ailment was somehow somebody famous was linking it back to their clitoris or masturbation or their sex drive. I mean, truly wild, from the way you breathe to the way you walk to the way you reproduce to what you eat. Absolutely mind-boggling.
To bike riding.
Yeah, the bike riding one. Yeah, I like to tell everybody, that's why I'm so fit. I'm on the Peloton all the time. Apparently that's why my endurance is so good. Like my VO2 max is high because these doctors would say I'm masturbating on the bike.
Oh, yeah.
Actually, no.
No, we wouldn't want to have that now, would we?
No.
You'd be strong and smart, and we can't have all of that at the same time.
No.
But these attitudes have really persisted straight through to today. Because when we're talking about women and sexuality and how this shows up, and be it how we talk about hormones, how we talk about testosterone, or how we talk about any of the medications that are out there that are really for women's sexual pleasure and their quality of life, we're lacking still.
You know this better than anybody else. I mean, I'm a breast oncologist. So the whole idea of any hormone replacement therapy throughout my training was, oh my God, never. It will cause breast cancer. They were on HRT. That's why they have breast cancer. Everybody who does HRT is going to get breast cancer. I mean, not only did I not have any training in it ever or menopause, but this was absolutely something you could never do. And I still think there's no training on testosterone. What do we really know about that we teach medical students? Probably nothing.
Well, it's interesting. The whole history of hormones for women, it's been around since 1942, so not new news, but it didn't really catch fire until about 1966, where we bring in yet another man, Dr. Robert Wilson, who wrote the book. And I always forget whether it's Forever Feminine or Feminine Forever, one of those. But he wrote this rhapsody to hormones, and he really brought it out to the public's sphere, talking, and he was, rhapsodizing about the wonders of hormones because it was going to help preserve women's beauty and sexual function, not for themselves, but for their husbands.
There's a great, I have it in my book. There's a guy, I think he's from the mafia, that comes in and holds a gun holds a gun to the doctor's head, basically, give my wife hormone replacement therapy so she can take care of me in my dying years. And I think he also refers to women as kind of vapid, empty cows as they age. So, nice imagery.
This is where our worlds collide, because as gynecologists, we spend a lot of time not just talking about gynecological issues, but we're talking about women's breast health all the time. And this would not be an uncommon scenario. Okay, so we have someone who's diagnosed with breast cancer, and as you say, now we sort of give them to the surgeon, but after their surgeon, then they come to their medical oncologist. And as you were saying earlier, tell us just about what would you say to a 40-year-old woman with breast cancer, and you were talking about, okay, so she's had her surgery, and now you are talking about what her treatment is going to be afterwards.
But people see a medical oncologist to really decrease the risk of what we call metastatic disease, which is breast cancer cells living in another part of the body. So breast cancer cells that have migrated to the liver, the lung, or whatnot. And when a woman has had early stage breast cancer and we're trying to prevent incurable metastatic disease, which is treatable but not curable, we see a medical oncologist to try to understand the biology of the cancer and how we can try to decrease the risk of that coming back. In your field, in terms of hormones, we know that about 2/3 of breast cancer patients have what's called the estrogen receptor that lives on the outside of those breast cancer cells. And in some instances can use estrogen as a pathway to help grow the cancer. It's not that simple, but that's part of the cascade of growth that we think about and how we target trying to decrease the risk of what we call metastatic disease. And we do that with different medications. If a woman is premenopausal and has a very aggressive cancer, sometimes we shut down her ovarian production of estrogen. And if a woman is postmenopausal, we may also be giving her something that drives down the production of estrogen, not just in her ovaries because she's menopausal, but other cells in her body. And so for premenopausal women, I know I'm giving you a detailed answer, but the details are important here. For premenopausal women, sometimes we shut down their ovarian function and give them something else on top of that either drives down estrogen, something called an aromatase inhibitor, or we're giving them something called tamoxifen, which blocks the ability of estrogen to bind to that cancer cell. Now, we know through hundreds of thousands and millions of women and lots of different studies that these medications can decrease the risk of cancer coming back, and they've improved cure rates for cancer. But the problem is, and we know this for postmenopausal patients as well, but the problem is that many of these women have significant side effects. They can have loss in bone density, loss of libido, they can have vaginal dryness, so many things that we've not addressed in the history of medicine for women because we've essentially offered the narrative, you're cured of your disease, or we're curing you of your disease and you're living, you should be grateful. But all these other things don't feel good. And there's no way that we would be doing this to so many men and not have better solutions. And so I'm really optimistic because so much of the conversation that we're having now is about addressing some of these side effects. And it's a lot of what my day-to-day job is like.
Well, I think that's a lot of what your day-to-day job is like. I can tell you that from the patients that I've seen who come back from their oncologist, that's a conversation that's not had. It's very sort of laser focused on their breast cancer without taking into account what does this mean for you for quality of life. And that's a through line through all of the medical specialties. You
Be grateful.
surgery for something else. It's like even our gynecologic colleagues will say, sure, let's take your uterus out and your ovaries out. And then they just walk out of the hospital with not having any conversation about what that means and whether or not there is even another option about how to treat it.
I think one of the things is when I don't have that long of a career, but looking back, certainly in the early stages of my career, is how many women have suffered. And I didn't really appreciate that level of suffering, or we didn't know how to address it. Even just the idea of the intravaginal estrogen, which we know is largely safe in breast cancer patients and can really transform the vaginal tissue and improve urinary and sexual function and day-to-day function. And how is it that so many women were telling me that sex feels like sandpaper and razor blades? And I'm like, oh, well, use some, lube and that should make it better. Like have a glass of wine. I mean, horrible, horrible, horrible. And you can't in one breath say that we've ignored women's sexual health and then not address the biology that so many women are suffering from, particularly those of my breast cancer patients.
A lot of the things that we think are true, I say, well, let's see some data on that. And that's why it's so important that we sort of include women in this conversation and really in the clinical trials. There's no doubt in my mind that whatever we think today is true, 50 years from now, we'll be doing it completely differently. And we'll be looking back the same way. We're like, can you believe they did that?
But my hope is that we'll have some humility in that. That unlike so many of we do. I think we do. I think
we do. But I mean, medicine writ large. Is there humility in that?
No. And I think that because we don't have the humility, we often blame the patient, right? This is why there are so many syndromes, the autoimmune syndromes. 80% of autoimmune diseases are in women. We don't really know what's going on there, right? I mean, we think we do, but yet we don't have even disease names for so many of these things. And so we assume that the woman is anxious, or she's just tired because she's a new mom, or achy because she's like lifting babies too much, when really she may have an underlying disorder that we have yet to even name. But I think a lot of us have a lot of humility and hope that look forward to being proven wrong. And I think the more we can think outside the box and recognize that we can't keep drinking the Kool-Aid of the past will ideally improve the landscape moving forward.
But this is a wonderful time to discuss, as we're talking about how women are sort of dismissed, not involved in this conversation. And certainly hormones, menopause is a big part of it. And again, our little overlap here about menopause as it relates to breast cancer and whether or not hormone therapy causes breast cancer. It doesn't. Would you agree? I said that. Now, would you agree that hormone therapy does not cause breast cancer? I'm going to say that. Yes
no, I don't think that it unilaterally causes breast cancer. I think there may be isolated situations that we still have to uncover and be more detailed about. But this whole narrative that if you take hormone replacement therapy, that you're doomed to get breast cancer is simply not true.
Yeah. And I think that we have to acknowledge the fact that there's breast cancer and there's breast cancer. There's not all breast cancers are the same. Mm-hmm. So, what the risk profile is for one is different from the risk profile of another.
Yeah. And not all breast cancers have that highly expressed, what we call estrogen receptor on the outside of breast cancer cells. One thing that I'm really interested in is patients who've had something called triple negative breast cancer, which is about 20% of breast cancers. These are cancers that don't express something called the estrogen receptor, progesterone receptor, and something else called the HER2 receptor on the outside of their cancer cells. We have no idea whether these women really can't do hormone replacement therapy after a diagnosis of breast cancer. They could have had chemotherapy that shut down their ovaries years ago. They've been menopausal for many, many, many years. Maybe through their 30s, and we've not historically been able to give them anything and say that it's safe. And I think that's a huge population of women. When you think about how many millions of women are living with breast cancer in the United States, that we should really be studying more.
This February, I've been thinking a lot about how we show ourselves and the people we love a little extra care. For me, that starts at home, and Cozy Earth makes it effortless. Their bamboo pajama set is lightweight, soft, and keeps you perfectly comfortable all night, so slipping into bed becomes something you actually look forward to. And their classic cuddle blanket Rich, plush, and irresistibly cozy. It's like a warm hug you never want to let go of. Cozy Earth is all about elevating the everyday with better materials, thoughtful design, and long-lasting quality. Whether it's for self-care or a Valentine's gift, their products turn simple moments at home into little escapes of comfort and calm. And the best part? You can try anything risk-free with a 100-night sleep trial and a 10-year warranty. Honestly, once you feel this kind of comfort, it's hard to go back. Share a little extra love this February and wrap yourself or someone you care about in comfort that truly feels special. Head to CozyEarth.com and use my code SECONDOPINION for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here. Celebrate everyday love with comfort that makes the little moments count. Starting something new isn't just hard, it's scary. I remember before I launched my practice, the doubts were real. What if I fail? What if no one listens? What if I'm not ready? But stepping forward anyway was one of the best decisions I ever made, especially with a partner like Shopify to make it easier. Shopify powers millions of businesses worldwide, from household names to first-time entrepreneurs. With hundreds of beautiful, customizable templates, it's easy to build a store that reflects your brand. AI tools help write product descriptions, headlines, and even enhance photos, so you can focus on patience or your craft. Marketing is built in too, with email and social campaigns that reach your audience wherever they are. Inventory, payments, analytics, it's all in one place. And with Shop Pay, Shopify delivers the best converting checkout on the planet, so more people complete their purchases. If you're stuck on what if, maybe this is your sign. Turn what if into what's next and start your business with Shopify. See less carts go abandoned and more sales go with Shopify and their Shop Pay button. Sign up for your $1 per month trial today at shopify.com/secondopinion. Go to shopify.com/secondopinion. That's shopify.com/secondopinion. All right, so let's just talk. We get back to, because there's so many things, there's so many directions we can go from this, but I really want to talk about menopause and all these symptoms of menopause. And so let's go back historically before we get to even our hormone therapy. And women would get to be midlife, they would start to have these symptoms and hot flashes and mood swings and whatever. And enter its ugly head, hysteria. And what the prevailing medical thought was about menopausal women. Give us
I think
a
it wasn't
picture.
just menopausal women. I think it's women at any point. So hysteria comes from the Greek word for womb. And initially there was this idea that women had this wandering womb that made them nuts. And then they realized with anatomy that it's actually tethered. It's not wandering, right? And then with the discovery of estrogen, it's even worse because it's not just the wandering potential womb that makes you crazy in the ovaries, but it's the estrogen that we're all bathed in. Every cell in our body is what makes us crazy. And there's so much, it wasn't until 1985 that DSM didn't even remove the term hysterical. Hysteria as a diagnosis from the DSM, right? So the whole idea, when I give talks and I say, how many women in this audience have been referred to as hysterical? The number of women that still raise their hand is shocking. And I don't think it's just menopausal women. I think we were doomed historically. If you're menstruating, you're crazy. And that's why you can't be president, because all your hormones are going to fluctuate up and down. And if you're postmenopausal, well, that's going to make you hysterical too. So you're screwed no matter what, simply because you're a woman.
And then, and it has resulted in so many women suffering.
Yeah.
This is also a good time for us to talk about, because race rears its ugly head in everything. Not just in the use of hormone therapy or not, but even in breast cancer. So tell us a little bit about the disparities in
the disparities are shocking.
Cancer.
So for Black women diagnosed with breast cancer, they are 40% more likely to die than any other ethnicity, and particularly Caucasian women. And when you look at the facts behind this, it's really not the biology of the cancer that they're inherently being diagnosed with. There may be some differences in some subtypes, but really what's driving this is a lack of resources and access, and that Black women are more likely to not have access to a tertiary care center, meaning an oncologist who isn't just treating every kind of breast cancer, but an oncologist like me, where we've trained solely in breast cancer, where we know the latest and best new treatments. They're less likely to have access to quality mammography and board certified radiologists who specialize in breast imaging. And when you don't have the same level of resources and you don't have the same level of access, when you don't have the same level of insurance, you are less likely to have routine imaging, to have access to doctors who can catch a cancer early. And when you catch it early, you're more likely to survive. The other really important point, and this goes back to Marian Sims, is that access to clinical trials, we know, can improve outcomes. And, there's a huge distrust, understandable given the history of medicine around Black women. But clinical trials can be an extraordinary way to have access to academic medical centers, but also newer treatments that are not paired against a placebo, but you're often given standard of care, something that we know is the best that we have that's approved, versus something standard and potentially better, and we don't know. And we know that historically, Black women are not as featured in clinical trials. And that's a very complex, complicated problem that has redounded to potentially worse outcomes. Yeah.
So I love this conversation because to understand where we are, Dr. Comen, you have to understand how we got here. It didn't just come out of, the clear blue sky. This is our history. Acknowledge it, and we're not going to rewrite history. We don't want to vilify people, but by the same token, I think that we need a fuller picture of who we are, because otherwise we're not going to change the system. Wouldn't you say? That would be fair?
Okay. That's why I wrote the book.
Well, I am going to, before we leave, I like to do a little something, because we do a little lightning round, because
I'm ready.
I'm going to put you on the spot here.
I like being put on the spot. Let's go.
Okay. I'm going to put you on the spot. All right. So for all our listeners, so they understand. All right. So someone has had cancer, breast cancer, vaginal estrogen after breast cancer. Yes or no?
Yes.
All right. Hormone replacement therapy after triple negative breast cancer.
I think it depends on, sometimes triple negative breast cancers can have a little bit of progesterone in there. I think it depends. I don't think we have enough large scale prospective randomized studies to say that it is as safe as something like vaginal estrogen. I'm not opposed to it, but it requires a good conversation.
All right. So another little thing. So we're going to talk about, what about a patient with DCIS? And for those of you who don't know what DCIS is, that's ductal carcinoma in situ, which is basic stage 0 cancer. Yeah. And you've had your surgery.
Right. You've had your surgery.
Would you hormone therapy after that?
It depends. If this is a woman who has a strong family history and we're worried about a future estrogen receptor positive breast cancer, maybe not. That may be too scary for her. We may not have enough data in that setting. She's older, or again, this is an informed conversation with patients. I'm not necessarily opposed to it, but I think it would be bad medicine to say unilaterally that it's fine.
For people who have DCIS and you've been treated and you've got negative margins and you are symptomatic, I'm not,
if there's nothing else that we could do, and we really believe that the hormone replacement therapy is going to help you live better, exercise, sleep better, and have a better quality of life. Yeah, I'm not opposed to it, but there needs to be some understanding that yes, the DCIS was removed. Is there anything else that the soil of your breast may be more predisposed to? Have we done hereditary genetic testing? I think that we just don't have perfect answers here, but I'm not 100% opposed to it at all.
And I will concede that no one has perfect answers, but at the very least, I think that what happens, that we see a lot, that women come in and they are begging for relief, because you're 42 years old and you've got DCIS and you're all good and ready to go, and you are debilitated by your symptoms. And I think that's the key. We're not saying, oh yeah, everybody take it. Not the case, but And I will think this is one better, because this is where we run into sometimes problems with oncologists. And that is, we've had that conversation. We've had the conversation. You've seen me, whatever, I'm a whatever. And we've had it. We've discussed it. I've told you what we know, what we don't know.
And they're on it.
Pros and
fine.
And the patient says, yes, I want it. I'm on it.
Good.
I prescribe it.
I have those patients in my practice who've been rejected by other oncologists who won't be followed. I'll follow you. I'll see you. I just don't know all of it in the same way that I know a certain chemotherapy has, like, in hundreds of thousands of women, has this potential outcome. I don't have that same large aggregate data, but I'm not opposed to taking care of somebody or helping them and working with them.
All right. We're gonna leave breast cancer for a moment here. What about the multi-panel cancer screening blood tests? Yes or no? There are a lot of them out there these days.
Yeah, there are a lot of them out there. And I think this is where it's really important to know your family history, potentially on your mother's side and your father's side. A lot of times people think they just inherit their cancer history from their mother, and it can be complicated. You've got to know your mother's side, your father's side, and also all the cancers to really have a sense of what you should be tested for. Now, some people have different fathers that they didn't even know about. Some people are adopted. A lot of people don't know their whole family history. But if there's any concern about that, really talk to your doctor about which panel is appropriate for you. These tests are cheaper and cheaper. And I do think that they're a good idea for many patients.
Thank you so much for being here, Dr. Comen. We could go on forever and ever. And remember, when we have areas of disagreement, just know that's because there are opinions in medicine. That's why they call them opinions. If we knew the answer, we'd all be doing the same thing, right?
We should have dialogue. I love dialoguing with you. And I think that we should all really cherish you and support you in breaking down so many barriers, having these conversations, putting people together for these types of conversations is really so important. And I feel really honored.
You are so welcome. And I love smart people. So trust me, when something else comes up, I'll have you back. It's time for the last part of my show where I give my doctor's orders and leave you with takeaways from today's conversation. Number 1, the historical dismissal of women's pain, especially Black women's pain, must be named and corrected. Number 2, quality of life is a legitimate medical outcome. Sexual health, vitality, cognition, and daily functioning matter in menopause care, cancer care, and all of women's health. And number 3, good medicine requires humility and partnership. Medical care should be collaborative, not prescriptive. We must abandon the paternalistic model of medical care to be truly effective. Join us each week on YouTube or wherever you find your podcast. If you enjoyed the show, follow us so you never miss an episode. If you like what you hear, leave a review. Until next week, take care.